equity in cancer care. So just some quick logistics. Please feel free to post questions in the chat during the panel discussion. The plan for today is to start off with introductions of our panelists, then we'll turn to our discussion, and finally we'll open it up for some questions. The panel discussion will focus on identifying tangible ways we can better support cancer patients and screenings from diverse communities in order to reduce the health disparities and inequities that we've heard about from Drs. Mendoza and Mitchell earlier this morning. So before we get started with our panel this morning, I'd like to take a moment to highlight our panelists' work and contributions to diverse communities in the greater Seattle area and beyond. Dr. Al-Ashkar is a family physician and UW faculty at the Department of Family Medicine. He completed his medical doctorate at Aleppo University in Syria and his residency at Florida Hospital. He has a master's in clinical research and a PhD in research methodology in education from Indiana University. Dr. Al-Ashkar's research spans topics like health policy, especially related to pain and opioid prescribing, patient experiences with a focus on lung cancer patients and survivors, and education frameworks for residents to learn reflection, self-assessment, and peer evaluation. He's also a cancer patient telling his own story of his health journey to bring a greater understanding of the gaps in cancer care and other issues. We heard some of his music as we transitioned into this portion of the program. Thank you so much for being here today. I'd also like to introduce Rahel Schwartz. She's originally from Ethiopia and completed a double major in biology and chemistry and then her master's degree in public health, specializing in health education and promotion. She currently serves as the Health and Wellness Director at the Meredith Matthews YMCA. She has facilitated the WISE Diabetes Prevention Program, Actively Changing Together program, and Live Strong program, while teaching Zumba and hip hop classes. Her work in chronic disease prevention underscores her personal goals of achieving health equity and eliminating avoidable health inequities and health disparities. Also on our panel is Lua Pritchard, who serves as the Executive Director for the Asia Pacific Cultural Center, or APCC. The APCC represents 47 countries and cultures, offering programs and services honoring their distinct artistry, business protocols, history, and social practices. In addition to connecting community members through culture, Lua's work also provides youth with after-school activities, COVID-19 relief efforts, and other essential services to best support Pacific Islander community members. So thank you all so much for being here this morning with us. Lua, I'd like to go ahead and start off with you. In your experience, can you talk about what types of cultural issues have arisen in the communities that you serve and that have been challenging in terms of meaningfully addressing cancer care?
With the AAPI, the Asia Pacific Island Community, cancer is very serious, and I'm sure it's serious for everyone. But it's even more serious for our people because it's very sacred. It's a sacred matter, and our families and friends and community look at cancer as something really, it's like near death. And although that there are so many remedies to many different kinds of cancer, but they don't necessarily, our people don't necessarily know that right off. And trust is so important. Trust is important in the sense of doctors and nurses and whoever is involved for the information given. And so family, our people normally reach out directly, like grabbing our family members to be there. So it's so important for our people to be there, family members to be with the people. It's so important that that trust is there, and to even go further. And because that creates hope and that creates love. Immediate love is very much needed. So that is the gravitation need that needs to, and doctors and nurses need to understand that they have to have, before the message is delivered, about the diagnosis, family members very important to be there right away, or a trusted person for that particular patient. So trust is huge. How even different countries have different ways of receiving these serious messages. So that's why it's so important. And then for the listeners to expect anger, and who's there to receive that immediate anger or that immediate fear that's going to come out in such a way. And there's quietness also that could be there. I mean, silence could be very there. And then clinical people are waiting for a while to get there. So that's very crucial right away for our Asian Pacific people.
Thank you so much for sharing that, Lua. Rahel or Dr. Al-Ashkar, do you have any comments to add from your experience?
I think in my experience, working in most of the time in East African and other African-born populations, in most of these communities, culture shapes, their beliefs about health and, other chronic illnesses. And this includes like their expectations, concerning, disclosure of, their diagnosis or prognosis. And then also family decision, making roles, language, perspectives, concerning alternative medicine. This all have a direct impact, in cancer care. But the most common cultural issues that have been challenging include medical communication and also a lack of social support. There are medical insurance concerns. So majority of the time, people are reluctant, to even ask questions or share their problems with their medical team, having no one to accompany them in a lot of cases where people don't have any guardians, to their treatments or appointments. And also, difficulty completing even or understanding health insurance paperwork. My daughter is a cancer survivor. She was, diagnosed when she was 5. And I have been living in the United States for over 30 years. I have been educated here. But for me, even to navigate her care, coordinate with the oncologist and, other issues that arises that majority of, these communities who are not familiar with the medical system, in addition to, their concerns, these are all challenges. So people, and also I think one of the major things is stigma. Stigma is attached to every chronic illnesses in our community. So this have been, as a facilitator for different chronic disease prevention programs, have been challenging, to address, whether it is cancer or diabetes or hypertension. So these are, the common barriers that, I have experienced in providing care or preventative care programs to these communities.
Thank you so much, Rahel.
Thank you, Myra, for including me. As you said, I'm from Syria originally, so I am immigrant. One of the things that still sits on my consciousness is that when I migrated here, I got the permission to come to the land by seeking that from the colonizers. I have not yet had the chance to seek it from people who had the land, who owned the land, and we are on occupied Wamish land here in Seattle. I'm from Syria, and I'm remembering that today as my people also experiencing oppression in Palestine by similar colonizing force. When you ask the question about community, I think of multiple communities that I am a member of. I am an immigrant, but when I developed cancer myself, I became a member of the cancer community, and my heart goes with every person who has cancer. I was diagnosed with stage 4 lung cancer in 2016. Cancer changes the person's life course, gets the person into a crisis. You have a project, you have a plan, you want to live, you have work that you're doing, you have family that you want to be with, so you can encounter events, so you can build memories together, so you can die when you get older, when you're 80, 90, or whatever age you set for yourself. Cancer comes, shifts everything around, and your world is upside down. Takes a while for you to adjust and build resiliency. But the notion of resiliency will continue to be with us. I heard a talk by somebody who's saying, I wish that people stop wishing me or stop recognizing my strength and resiliency. I wish somebody just recognized that I want to be weak and I want to falter, and I need your support, I need your help. People with cancer need that help. People with cancer who walk around with a smile, with strength, they're putting effort to maintain that. So when I asked people, I interviewed 40 people with stage 4 lung cancer who were living at the time when the disease is starting to become like a chronic disease. They said first and foremost, they want understanding. They're struggling. Their cancer is an experience of struggle. They want understanding, they want emotional support from others, they want their disease to develop into a chronic illness. They recognize, especially with lung cancer, huge stigma, as Myra mentioned, as Rahel mentioned, related to smoking. So, have you smoked? That's a question I get asked all the time when I say I developed lung cancer. It's as if the person wants to find a reason for my cancer, for its development, so they can themselves feel like, oh, I'm immune, it's not going to happen to me. They smoked, they got it upon themselves, and I do not even need to empathize with them. So that's a problem. Stigma is affecting not just the person's access to empathy, but also the community's access, the cancer access to research. For example, lung cancer historically been underfunded compared to other cancers that are more appealing and more easier for people to empathize with the people who develop. Second, I talked about understanding, I talked about emotional support, I talked about research to continue to develop more lifelines for the individuals. As our cancers, with advancements of treatment developing into a chronic disease, people want their healthcare providers to understand that and to support them to set their goals for care. I want to live. I was 33 when I was diagnosed with cancer. Now it's been 4 years since then, and I want to live. I want to live until I'm 88. So when I set that as a goal, that means I'm going to look for the second lifeline, I'm going to look for the third lifeline, and when those fail, I'm going to find clinical trials until my body's tired and until I cannot do it anymore. I will live until I cannot live anymore. But if a healthcare provider says you have a stage 4 cancer, this is, there's no hope for you, that would be daunting to me. I want my doctors to be on my side, and I want them to engage me in the conversation to set goals of care. Those apply to all the cancer community, and again, I belong to that community, and we're solid. We stand in solidarity and support for each other, and we understand the agony and the struggle of other communities, we in the lung cancer community. As my work as my work to become anti-racist, as my efforts myself to learn and to participate in that conversations, I interviewed people participated with others to develop a group to launch a project. We called it Project Radical, which is racial inequity at the cancer of the lung. So Project Radical, we interviewed people who have lung cancer, similar to mine, from African American communities. We also interviewed activists in the community. We're interviewing healthcare providers as well to come to understand what happens on the diagnosis pathway for a person who's African American, who's Black, that's then leading to this disparity that we're observing, this pervasive disparity that we're seeing in the lung cancer experience of people who are Black in our community. We're also specifically here, and I'm talking here about an opportunity. Lung cancer is turning into a chronic disease. simply because there are genetic testing, there are molecular testing out there. If you find, just like myself, if you find that you have a mutation, you might be eligible to treatment. Your life could continue as a chronic disease. If you're not offered that test, you're less likely to survive. You're going to live with this as an end stage. Within 4 to 10 months, you're going to succumb to demise. So if the person is given that opportunity, they could live. If they're not, then they're going to die soon. And that's where you have the outcome improving for some groups in the community, those who have privileges, and they're staying to be poor for others. And that's the work that we're doing. We're finding that yes, trust is a main factor, as has been mentioned today. But trust has to do not only because of our historical terrible deeds with Tuskegee trials or others, but also because of the encounters the individuals actually have themselves with the healthcare systems. And here I'm speaking to my colleagues, to the doctors, that be careful, because something that you do today could affect that person's perception of the health system, of you, of other colleagues, as people who would come and be needed at some point, so they can provide care when it is needed. So it's very important to provide that support for the person, to provide that authentic care and that genuine recognition of the person. Any dismissal of the person when they come with a concern, then later on when they come with a serious one that could be cancer, could lead to delays in diagnosis because, again, of that learned mistrust in that encounter of the persons themselves. Third, community. I am immigrant. I'm Syrian again. My people in Palestine are struggling today. I will just tell a story of a friend who actually works on Amazon. Now went to visit his family in the Daffa. His brother died of cancer as well. When he was there, his 2 years old son was found to have ALL, acute lymphocytic leukemia. He was in the Palestine occupied territory. Panicking, he had to go to Jordan to take him there for a better care, because he knew that the care that's available in the occupied land is not good. He's going to be in Amman receiving care at a cancer center that's good, that's following good protocols. I, as a person who does research with cancer, who's a cancer patient, I am aching, I'm struggling, because I know that if you receive care here in the United States at one of the recognized cancer institute, your outcome is going to be different. It's going to be better than if you're receiving care at a local oncologist somewhere, or at a rural site from a local oncologist who may not have the cutting edge experiences. I am worried about my friend who has access to be in Jordan, who's going to come later to be in the U.S. after they go through the visa, which is a hectic process, torture for my Palestinian people, my families in Palestine, my people in Palestine. Imagine the person in Gaza who's been for the past 14 days being bombed, who hospitals are being bombed, the doctors are getting killed, they're not getting access to the treatment that I have, they're not getting access to the basic care, they're getting killed. Over 200 people are dying. When we speak about disparity, we need to speak about it in an international solidarity framework. Every person, every life on this planet is sacred. My community here, my community there back home, they're my people. And when I speak on their behalf here with the voice that I have as a person with privilege, as a professor in the university, I want to bring this attention to everybody. We cannot say, I'm going to improve outcome for this group of people or that group of people. We need to speak of every group, every marginalized person, every person that's not heard, our community of color, the natives, our Black communities, our Arabic community, whether they're here, our Palestinians, whether they're here in Washington State, in Seattle, or whether they are back home in Palestine under the occupation.
Thank you so much. I really appreciate your comments, and I think, we know that a cancer diagnosis is terrifying in and of itself, much less if it's overlaid by war and violence and a host of other issues that a lot of our communities are facing, and particularly over the past week. So I really appreciate you speaking to that this morning. I want to also begin to unpack some of the comments that you all have made. I think there's a lot of complexity here. There's a lot of nuances to being able to provide the appropriate supports to diverse communities. Dr. Mitchell talked about a multi-level approach, so it's not just at the individual level. There's also a need for providers to understand and families to understand what they can do to support an individual who has a diagnosis. And there's also roles for organizations, our cultural organizations and other supporting institutions in our communities to focus on prevention and also screenings in particular. And Rahel, I wanted to ask you, what are some of the challenges that you face in helping to connect the need for prevention among communities you serve to some of the health outcomes that we've been talking about today with regards to cancer? And do you see any opportunities for providing improved supports to the communities that you serve in this area?
Yes, I think in providing, as a facilitator for the Ethiopian and Somali and different East African communities in South King County, one thing that I have realized that the only reason that we have been successful in engaging with those communities to provide preventative care is working with trusted community members, which includes like the Ethiopian Community Center. We've been working with them since I work for the YMCA to provide, diabetes prevention or a nutrition class or these classes at the community center, because that is a place that a lot of like seniors, people who don't speak English or are new to, just immigrated to United States, that is the one place they can go to provide, to receive social services in different, in different areas, in different needs. And I was able to go there on a regular basis, but the most important thing is relationship building and not approach communities, based on your own biases or based on, a lot of times, organizations say, well, based on data, these are the health issues that you are experiencing. So we are going to come and give you this, instead of asking the community what are your immediate needs are. Diabetes might be the issue or cancer might be issue, but if they are struggling to feed their parents, what are the other social determinants of health affecting these communities? Because health is not about providing programs or preventative care. It's about caring for caring about their whole health. So it may be food access, it may be language barrier, navigating the healthcare system. So those are the things that we have to address. And the other thing we have done at the Y is hire community health navigators and train them to facilitate and to engage with the communities. They know the culture, they know the traditions. Even I am from Ethiopia. I speak one language. In my country, there are 86 different languages that are spoken. There are different cultures within my cultures that I am not, I'm not an expert, to speak on. Or so finding, I think the most important thing that we need to do is building relationships with communities. In addition to that, finding out what are the community needs are. Once you address those issues, then people won't be reluctant when you come in as a trusted messenger in trying to communicate, whether it's cancer prevention or diabetes prevention. Then then you will have a positive response. But I think I always say that nobody is culturally competent, but we all need cultural humility and to be able to meet where people are instead of, coming from a perspective of we know what you need, so we are going to, give you this. And I think that is where the mistrust comes in. I think the most important thing is, provide services based on their own needs instead of our own biases of what people think, like what we think they need. And in even, with my own journey with my daughter, I had so many issues at the doctors trying to communicate with me about my child's cancer care, where people treat me based on their own biases. They treat me based on what they think I am, not without learning anything from me. So that creates another barrier. So I always used to say, I can advocate for my daughter. I can speak. I can read. I can find out what she needs. I can find a social worker who can connect me to different services while I'm caring for my daughter. But how about the rest of community members where languages are issues, accessing, when you are caring for your child, that is within itself, that's a big thing. You don't have any time, to investigate or to find out what other services are provided. So there has to be, a way that healthcare providers have culturally competent health navigators who are working full time among the healthcare providers to provide this support, because cancer changes you forever. You will never get back to your normal. Your new normal is going to be much different, despite you're over, cancer and you're a survivor. And those are the things that a lot of times people don't recognize, including, healthcare providers. So I think those are the things I believe that will help us be successful in communicating and providing cancer care.
Thank you, Rahel. Dr. Al-Ashkar, I want to get back to some of the comments that you made about some of those specific actions that providers can take with regards to addressing inequity in cancer care in a meaningful way. I know we hear a lot about the intense pressures that providers are under from a variety of factors, and now, of course, with COVID-19. And I just want to ask you if you can speak to, some of the tangible recommendations that you would recommend folks take to be able to address some of these inequities that we've been talking about today.
Yeah, thank you for this. Is a really good question. The assumption, obviously, is that a person has a provider. Many people in our communities do not have a healthcare provider that they can trust and they can go to. So that is a problem. Making that available to people through everybody needs to be insured through free healthcare. I don't need to be afraid of going to the doctor because of the bill that comes out that could take me into a bankruptcy. So those needs, some of the structural and systemic things need to be addressed. If I am seen by the doctor, and we've done this work, we looked at the diagnosis pathways for lung cancer and what takes place both at the phase where the patient is dealing with the symptom to when they go to the doctor and have a conversation about it, to when the diagnosis is made and they're starting now in the secondary care phase where they're seeing the oncologist. With the primary care doctor, the person comes to me with symptoms that are vague. So as a primary care doctor, for example, somebody comes with cough. Not every cough is lung cancer. Often it's not. Yet when somebody comes with cough, I need to be mindful that this actually could be lung cancer. I need to have a contingency plan. I need to have a safety plan for them. I need to let them know, hey, if this is not getting better in this many weeks, come back. We need to follow up with that. Yes, it could be cancer. So when it's time, I need to investigate. I need to check my biases at the door, so I can provide equitable opportunity. I provide the test to every person, not just for the rich and not for the poor, not just for the white and not for the person of color. So those are the person needs to be mindful of. Then recognize that the health system is ultra complex, and I'm speaking here as a physician myself, but when I am a patient, I struggle myself to make that appointment, to keep the appointment, to show up on time. I missed appointments, I showed up late, and it's been harder with work to actually find those. So being mindful that the system is complex, so doing whatever we can to be on the side of the patient, to provide the space for them, to provide them the access to this care, and making sure that things are followed through and things are not falling into the cracks. Those are really important. Back to the issues about the provider and not having provider. And Rahel, I appreciate you mentioning that the health navigators from the community. I would take that further. We cannot continue with this structure of our workforce where you have a person, if you go to a doctor's office, you're more likely than not being seen with a white provider. This is not fair. This is not equitable. We need to diversify our workforce. A person, and we know that there are studies after studies, shows that you're more likely to trust the recommendation if you can relate to the provider. We have not unpacked, we have not solved the issues of racism. We're encountering this on the street. So you're asking a person of color to go to the doctor's office to see people who are not looking like them, not at the front desk, not inside the office, to then tell them everything about their struggle, show their vulnerability, and expect them to get care and not be dismissed. This is not going to be the case. So one of the main strategies is to diversify the workforce. Diversify and including people who are from the U.S. in a sense, more Black, more Hispanics, but also with immigrant communities, with refugees communities. We need to shorten the pathway for people to join, to participate. I came from Syria. I did my schooling in Syria. Coming to get a residency, this is like winning a lottery. Getting a spot in residency, getting training, and then surviving training. And I did not survive my first residency training. I was fired because I was the worst incompetency that white racist attending have ever seen. When I went to a different place, I was the top 3 resident that program director in a diverse place ever trained. This is an experience that I lived. We need to diversify our workforce. We need to include people and representations from the community. You get better care until we check our biases and racism, until we grow to be enlightened people who are all anti-racist. We need to diversify our workforce. And even after that, we still need to continue to diversify our workforce, include our community, make the pathway easier for people who are trained outside the U.S. to join the workforce and work at the maximum of their capacity. This is a research that I'm doing with welcome back centers. Those are the groups, and there are a couple of them in Seattle. They find immigrants or refugees who are from those communities who have trained to be healthcare, to work in healthcare, whether nurses or doctors or physical therapists or whatever, and but they're not working. They're working as janitors, they're working in transportation, they're working as MA while they actually have an RN. So we need to support those people so they can work to the max of their capacity. They're skilled, they're talented, and they understand their community. They speak the language. We need to diversify our workforce. We need to include those. So when I as a patient come, I see people like me. I see a doctor who speaks my language, who can understand me and feel they trust, they care for me. They see me as a person, as a human, as opposed to an object or as a thing or as a number or as a quality indicator in the end. Then I think our care will be different.
So much. And I have one final question for Lua. You mentioned some of the emotional aspects of dealing with a cancer diagnosis, and it's something that we don't often talk about in terms of kind of the behavioral health needs for folks who are going through these types of things. and particularly from the perspective of diverse communities. And I know it's really hard to generalize across, tens of communities that you serve, but I'm wondering if you can maybe share with us some of the challenges in addressing some of those emotional issues that you were just talking about.
So, one of the greatest things that we fear is insurance. When we have chronic diseases situations, and cancer is very serious matter. So, and then all of a sudden we're hit with it, and the first thing that comes to our mind, how do I have insurance, and how are we going to pay for all this? And a lot of times, some of the family members won't even go further than that notice, because in many ways they will just find ways to tough it out or decide and miss so many. So insurance is so important. I think hospitals and medical providers need to really look into how they can simplify those matters, how they can assure families that they don't have to worry about that. As a community service provider, that's one of the greatest issues we deal with in terms of the people. The other thing that we deal with is immigration. The other thing is, if I go to the doctor, if I go to the hospital, are they going to report me there because I'm not documented and I don't have the right IDs and so forth? So those are big issues for our community as well. And are the medical providers ready for those questions and for those fears? You know what? The people won't come directly and ask them, but people like me, for example, APCC and KWA and other ACRS, other organizations who do serve our AAPI community, we will ask those questions. Those are some of the key questions. And like Rahel said, language is so important. How are you handling the languages? That's always my question to clinical providers. How are you handling, and how can you be friendly about that? Do you know all the providers in the community that you can reach out to for those matters? I get so happy all the time when I get a call from the school district or the hospitals about, can you help us with this language? Can you send someone over to interpret for this patient or for this student? We would be so happy to do that, but and clinical providers should not. The first thing in your mind should not be like, do I have to pay for this service? That should not be your question. Your question is to serve the client, the patient. Your question is, how can I serve this better? So don't think those kind of ways, and reach out. Don't be afraid to reach out. You got to know, and this is the time now. Collect all, make a list of who we are in the community who can help you. And that your staff can, and make sure all your staff know about it, and like Dr. Mohaf said, we've been singing that song forever. Diversify your workforce, diversify your workforce. And when you diversify your workforce, you also bring the language in, because a lot of us, we speak a different language than English. A lot of us were born and raised in our countries. So we come with those skills, and then we can also be helpful in connecting to the rest of the world for the clinical provider. Disaggregated data, that is so important. You have to disaggregate your data. Please do that, because we, the community providers, will come out to you and say, well, how many Samoans did you serve? And so, because that way, at the end of the year, you can figure out what community are you having trouble with, and so where can I get more help for that? So that is so important. Is disaggregating, and then I cannot express more. That Rahel did it, Dr. Mohaf did it. We need trusted people. We need trusted people we can trust, and that. I'm always singing this song. Doctors and nurses, I don't care what kind of training medically you have, but if you're not trained to help people, be friendly to people, and be a people person, you need more training or change your ways, because you can be the smartest doctor in the world, but if you don't know how to deal with your patients, I've watched my family, I've escorted my family members to clinical care so many times. And I've watched how the doctors and the nurses convey with my family members. And I'm telling you, I have not been very satisfied. And so we really need the doctors and the nurses and the clinical, all of you staff members, to have more training in how to deal with people. So that I cannot express more on those issues. But we need, and when you're a people person, then that's the trust. That's where the trust begins. I don't have to be your sister or brother to trust you. And people don't have to have me as a sister and a brother blood in order for them to trust. It's the relationship that we build by being a better person, improve on yourself to be a better. Let us see your love. Let us see the love inside the heart of a doctor or the heart of a nurse or any medical staff. So we need that. We need that.
Thank you so much, Lua. I really appreciate your comments. It just reminds me of one time I was at CTAC, and I don't know where they were coming from, but they were coming from outside of the mainland US, and somebody was saying, "What's wrong with everybody? Why isn't anybody smiling at all?"
Yeah.
And their relative was trying to explain to them, they're okay, they're just, that's just the way they are.
Yeah.
So there's some things, that we have to be aware of, about our cultures that, are inexplicable. Sometimes it's hard to understand where we're coming from because of those cultural disconnects. So I really appreciate you sharing that. I think, we don't have time for questions right now, but I think what we've done earlier is if you do have questions for our panelists, if you can put them into the chat, we're sending them to them separately. And then if they have some time to respond to them, then we'll make them available to you all. I want to thank you all so much for serving on this panel. On behalf of the OCOE, I'd like to thank our audience and our panelists for your time today. We're going to take a short 10-minute break. And during this brief intermission, we'll be playing one of our episodes from the OCOE's podcast, Cancer Health Equity Now. And so we'll see you all after this 10-minute break. Thank you.
So the CCRC